Welcome to State of State. I'm Darlene DeRezzo, and I am in conversation with Mr. Bud Cicilline. Welcome.
Thank you very much, Darlene.
May I call you Bud?
Yes, of course.
Thank you. Okay, so you have quite the resume.
Oh.
Well,
I'm quite old.
You're born and raised here in Rhode Island. You went to LaSalle, you went to Providence College, and you received your master's degree at the University of Rhode Island in clinical psychology.
Yes,
all right,
that's
so
true.
Let's just start there. You know, your interest in psychology began when, and what prompted you to follow this path?
Well, interesting question. It started kind of young. We lived, our family lived in Federal Hill, and this woman across the street was and her husband were great friends of my grandfather, who was from Italy, and we were very close in the neighborhood. Anyway, periodically she would run out of the house screaming, and sometimes she was actually naked. I didn't know what was going on, but it impressed me. It was something was wrong with this woman, and it kind of was on my mind a lot. And then my family and we would go when we could to the beach, and we would invariably, the route we would take well before 95, we would go by the institutions, and I would see some people outside near a store shuffling around looking sad, and I wondered what was going on with them, and it always sort of stuck in my mind. So when I was in school, it was sort of something it sort of I thought about a bit, and then I found too that my high school classmates used to come to me and ask for advice or share stories with me and trust me with information and all that stuff. So I started to think about it a little bit, and then when another odd thing happened. I was at Providence College. I had dropped out, and I was in Miami Beach, just with another friend, and we were hanging around. I ended up going to the Miami Library and started to read about Freud. And when I came back, I kind of had organized my thoughts around becoming a psychologist after that. So 3 or 4 things kind of crystallized, if you will, and off I went.
Okay, now your first job out of school was where? Do you remember?
Yeah, I was a rehabilitation counselor for the state of Rhode Island, and it was a new program, and we were focused on youth. All the others, this was the first state in the country to be able to work with rehabilitation programs for younger people. So I started working with young people and visited schools in Cranston, Johnston, and North Providence. They were my, area, and talked to kids who had both physical and psychological problems. And while I was there, I started taking courses at URI graduate school, URI, the evening school, and met the professors. They were starting a program at URI, the first graduate program they had, and they asked me to.
In clinical psychology?
Yeah, right. They asked me to become a student, so I did, and I did that for 2 years, and had placements at the Women's Reformatory, the Girls Training School, and the State Hospital, the Institute of Mental Health. Yeah.
So this first position, rehabilitation, that was out of what facility or what institution? Well,
out of the state of Rhode Island, and it was within the department. Then it was the Department of Education, and it was the Division of Vocational Rehabilitation.
Okay.
And it was located in a building where the Providence Place Mall is now.
Wow.
So it was way back. It was a building called the Hayes Building, as I remember. Yeah.
In the 1960s then, so we're talking early, mid-1960s, Rhode Island delivered probably the best mental health care in the country, right? There was a time in which Rhode Island was noted for that, delivering the best mental health care in the country. Was it this period?
No, it was maybe 15 years later.
Okay.
At that time, I was in graduate school. I was going into the institution, and I was in the back wards, if you will, and stuff was pretty rough then. I mean, people were walking around in circles, taking their clothes off, smearing feces on walls, and it was a pretty difficult.
So you're talking about the early 80s, is that what you?
No, I'm talking now about the 60s when
okay,
things
60s.
were, pretty rough. And at that time, it was called the Institute of Mental Health, but prior to that, it used to be called the Institute of Mental Diseases. But that time, we had somewhere between maybe 2,500 and 3,000 people at the state hospital for psychiatric care. So it was pretty crowded, and deinstitutionalization didn't take place till at least 10, 15 years later, 10 years at least later, when there was a realization that people could do better if they weren't in the institution. And there weren't a lot of constraints back then. If a family member thought another family member needed to be in the hospital, it's almost talk to the family doctor, and the person went. And often the person got worse. Often they didn't belong there in the first place, but often when they were there, there's this phenomenon called institutionalization that causes people to, become like others in some respects, and they, degenerate in terms of their functioning and all that. And that took place, and that occurred, so many times. And finally, laws were passed that made it much more difficult to basically Shanghai people into a facility like that against their will.
But that being said, people with mental health issues, significant mental health issues and impairment, they cannot self-reflect, so they would not have the wherewithal necessarily to admit themselves. So I can see where there's
the law provides, excuse me, Tony, but the law provides in those instances for an evaluation, objective evaluation, so that a psychiatrist is expected to see the person and determine to what extent their capacity to make judgment is impaired. And then, as professionals, they're supposed to act in the best interest of the patient, not the system or the judge or anyone else. And so we rely on their professional judgment and their compassion for others to determine what's best for this person. So yeah, at some point when their impairment is so great and they're acting under pretty severe, significant psychosis, yeah, their capacity to make sound judgments is compromised. So we need someone who is able to help in that respect and not have like a vested interest in, putting this person in a facility against their will. So we are able to do that.
Yeah, so in the 60s then, new psychotropic drugs came out that we thought were going to change the landscape of how mental illnesses were treated, and unfortunately that did not go the way we thought. Kennedy passed into law.
The Community Mental Health Centers Act. Right.
Okay, so we had a decline in the way mental health is treated. Let's fast forward to the 80s when Rhode Island then did deliver some of the best mental health care in the country. And let's start there with what that looked like and how we got here.
Right, okay, that's a good point. So, in the 60s, as you mentioned, the legislation, there was national legislation. There was also legislation in the state of Rhode Island that was introduced by former Representative John Chafee, who eventually became United States Senator, and former Senator Eleanor Slater, and they introduced legislation that would allow for cities and towns to establish community mental health clinics. And if you are able to do it in your city or town or a collection of cities and towns, the state would match it. And so we began these mental health clinics. And that was the forerunner of what we would see later. And as you mentioned, psychotropic drugs were coming on the scene. They really started getting better in the 50s and even better in the 60s. And sometimes you do one and don't do both. It doesn't work very well for the patient. So here we have the community-based services that are alternative to institutionalization. As time went on, they morphed into what we call community mental health centers, which, is a higher standard, if you will, in terms of services that are expected. And we saw that happening in the 80s. At that time, it really in the mid-70s, Joseph Garrahy was the governor, and we had a director of mental health retardation in hospitals named Joe Bevilacqua. He was followed by Tom Romeo. These individuals understood the importance of a combination of community services and hospital-based services. But we also had the element of families involved. And that, combination or mix of things allowed for a lot of progressive services to take place. And we began to slowly but surely reduce the population at the state hospital. And during our period of time when we were doing this, it went from that 3,000 to 100 to 150. And I think it's probably still around there. I'm not absolutely sure now, but we took people in, we established group homes and other halfway kind of house type of facilities, other residential options, so that people could actually be closer to their families, live in their home communities, and interact with others and bring about. And then these community mental health centers would have day programs that would be a place where, not all of them went, but, a place where people could go if they had, they needed to be supported in some way. Now we have, much more, case managers making home visits and out in the community and all of that. But it was that combination of things, and we had great support from the legislature, the governor's office, the general public, and all that. And it was that combination made for us becoming number one in the country and number 2 or 3 for a few years after that. And then since then, well, there were some good things happened with respect to Medicaid coming in and beginning to be available to support some of these services. But as you know, Medicaid is a combination of both federal dollars and state dollars. And after a while, the state, where it used to fund and support some of the services that we provide, such as outpatient services and emergency services, began not to support these anymore. They were looking to save money, and they kind of left the system to figure it out itself and all of that. So meanwhile, what's happening is there's less, money coming in, and some of the staff just aren't getting paid, or there's no getting paid at a rate that they deserve and should get, and all that, and it would be competitive. And as a consequence, we'd have turnover, a lot of turnover, because they just couldn't, continue to be there. So we've had Medicaid come in and be kind of a lifesaver, but it's also, there's an initiative to reduce how much the state wants to pay for that, so services have been hurt by it. And we are in this current situation that's been discussed and brought to attention by many others in much more eloquent ways than I have, that, show that there's a genuine crisis in healthcare services with respect to compensation for workers. It's demoralizing, and it's, just hurting the whole system, and something radically needs to be done. And so, my message, if you will, is that the governor and the General Assembly must take this much more seriously than has been the case over the last 10 years or more.
Why aren't mental health care providers being paid well? And ultimately, it's the insurance companies that are dictating the rate.
Well, that's very true. The insurance companies have a major role in this, and with respect to it. But in terms of, the state government, I think, has a responsibility, and to help people who are in need, whether it's health issues, medical issues, psychological issues, whatever. But also, if they're poor, they have housing problems, or they have substance abuse issues, whatever. I mean, I think there's a responsibility, and it's not being met.
But some might say the state taking over as caregiver is not necessarily in the best interest of...
No, I'm not. Yeah, okay, no, I'm not suggesting that, because in fact, the state isn't caregiver in these outpatient services at all. And in fact, in my view, these providers are performing what would otherwise be a state function. So if they weren't doing it, and they're doing it at a much cheaper rate, the state would be obligated to do it.
Well, it would be like the state taking over medical care, is what you're talking about, medical and mental health care.
And
so it's not privatized.
Right, and there are thoughts and plans about insurance and a single provider or a single insurance company and all that. I can appreciate that, but it still has the work that needs to be done in terms of treatment, care and treatment must be done by professionals who are trained and and have the skills to do this sort of work. And I don't...
And compensated well.
Yes, and right. And I can't imagine the state, it isn't a direct service provider in a lot of instances. So I do believe that there's a need for a greater understanding and a greater level of support to understand and fund these providers at an adequate level, and insurance companies to be compensating at a rate that is reasonable. I mean, we have been challenged by having certain professionals in the state. It could go across all the board, but I know in my own experience, and this goes back almost 50 years, we've had trouble getting child psychiatrists in the state almost forever.
Oh, we actually did a show on that.
Oh, is that right?
Because, a child psychiatrist has to go through med school, adult psychiatry school, and then child psychiatry school.
Yes.
It takes 10 years.
Yes.
I would do that if I could.
Yes.
I work a lot with children.
Yeah.
So we do have sort of a crisis of providers and providers not
Yep.
being compensated well.
Right.
So what does the landscape of mental health services look like now in Rhode Island, and what do you want to change?
All right, well, there's one thing that we didn't touch on that I just want to mention, and it is something that is part of the landscape, and that is that there's a high number of individuals suffering from some form of mental illness who are in ACI, the Adult Correctional Institute. And people might ask, why is that happening? Well, the door to the hospital, the Eleanor Slater Hospital, psychiatric services, has been essentially closed for years because they want to keep the numbers down. And then there's another story that morphs into the problems at the Eleanor Slater Hospital. And I don't know if everyone has a handle on this, but if the number of patients at Eleanor Slater Hospital goes over to 50%, Medicaid stops paying for or reimbursing the state for those services.
Why?
So they want to keep the number down.
Hold on.
Okay.
If Eleanor Slater goes to capacity, fills their beds, they're not getting the funding from
Yeah, all right.
Medicaid.
Let's say, I'm not even sure the number. Let's say there are 400 patients at Eleanor Slater. If 201 of those individuals are deemed psychiatric or have psychiatric diagnosis, Medicaid says, hold it, you become essentially a mental health hospital or psychiatric hospital, and we don't compensate or reimburse for those services. So bingo. And that already happened. That happened during this past year, and for a period of time, for several months. The state went ahead and billed, and without realizing that it was over the number, the 50% number, and they got called on it, and then they had to stop paying, and they had to pay back and all that. Now, I think the ship has been righted and all that, but it still is, and in some measure, I don't blame the state because it's a stupid rule, as far as I'm concerned, coming from Medicare and Medicaid. I mean, they've instituted this rule because they worry about psychiatric patients being...
Well, that's interesting, because I always thought Eleanor Slater was a mental health hospital. It's not, is what you're saying.
No, it's both for persons with significant serious medical conditions, people with brain trauma, some people have been paralyzed, whatever. But there are a number of those individuals are at the Zambrano unit in Burrillville. But there are still others who are on life support and other things in the Reagan building in Eleanor Slater Hospital in Cranston. So yeah, it's not, Eleanor Slater is just, it's an umbrella for both psychiatric and medical.
So Bud, we have 10 minutes.
Oh, okay.
I know, right? Okay, so where do you want to take the conversation now? So I had asked about the current landscape and what you want to change. We can go there. There's...
All right. Well, let me just get back to what I wanted to mention about the ACI and all that. And, you know, a way of addressing that would be diversion. In other words, before they end up there, that they get diverted to some other program. Now, the problem is there aren't a lot of psychiatric beds, and the other issue is that we try to not institutionalize people, but we still need a facility for them to go. So the state hospital is keeping its level at this, you know, number because they're worried about, you know, not getting reimbursed and all that stuff. So we need, you know, a little bit more work done with respect to advocating with Congress and whatever to change the rules to allow for more psychiatric admissions to the state hospital. Because I do think overall, I mean, some people thought close it, like we closed Ladd School, let's close this one. But I do think that some people still need to be in a long-term care facility. So I'd say one of the things that we need to do to stop people being put in prison instead of hospitals is to change the Medicare rules, the Medicaid rules, so that we can, you know, do that. Another thing that we need to do, and I've suggested that some of the $1 billion that Rhode Island has been assigned with respect to the rescue money is that we develop a genuine system, not necessarily reinvent the one we had, which was pretty good, but, you know, do it even better. And what I mean by even better is that we need all these levels of care and options and all that, but we also need to certainly understand all the connections between everything. Housing is a major issue, and it's a major issue anyway.
The connection really begins in infancy.
Yes.
True connection, attachment. So I can say that the majority of my clients have some sort of attachment issues, you know, so there's, the mental health has to start there, with mother and child bonding, dads being around, people feeling safe and secure, right?
Absolutely,
Learning,
you're absolutely right.
Co-regulation and self-regulation.
Yeah, I agree with you. I was also going to add that, you know, we need to do more with respect to schools in greater understanding about, you know, psychological problems and all that. Bullying is an issue, and understanding, you know, people just be much more compassionate and interacting, and you know, developing ways to deal with conflict. I mean, things just seem to crystallize so quickly and ready to get into how we're different as opposed to how much we share. And so children need more help or support with that. And unfortunately, you know, there are prejudices that go on that, you know, adversely affect us. It really hurt us a lot. I mean, people get, you know, find a way to see differences in other people and then make an issue of it. And now, you know, forever it seems like, you know, there have been cliques and things of that sort. And we understand that in some respect, but we also understand how hurtful it can be if you're not in the right one, or you're being get, kind of put down every day. So we need to work with children so that they don't get ostracized and so they can get more support in the schools.
But who's we? Who's the we?
Meaning the system that we have, our educational system needs to concentrate on this. So I think more rules need to be addressed. Now, I was on the school committee many years ago, and I know that whenever we talked about trying to change things, in the curriculum or whatever, I was also always advised to say that, if you put something in, you have to take something out. So we have to reconfigure what we're putting in this system right now, what kids are learning, because as much as it is important that
why aren't these children learning this at home? Compassion.
Obviously that is a place where it all begins, as you mentioned earlier, and all that. But we also have to be realistic to deal with what we got when they show up in school and all of that. And hopefully it would, evolve into a situation where we could bring parents in and offer support to them about some issues where they might, not be doing such a great job. But I think a lot of, I think most people would agree it starts at home. Some kids are not very fortunate in having parents that are able to do what other parents seem able to do.
Right, so how to find a way to support those parents then?
Yes,
so
right.
Providing mental health services to the parents.
Right, and you got kids living in cars, and it's just like, and then do they really want that? I mean, do the parents really want that, or are they not doing it? Are they being irresponsible, or are they struggling and trying to make the best? We don't know. We got to reach out and do more with that. So there's a lot of work that needs to be done, and I'm not sure I have. That's a tough question. What needs to be done, but I know that a lot of people have good ideas, and then we kind of talk about it. But there's got to be the resolve, and there's got to be the support, and there's got to be the finances to go with it. We can't just talk about it anymore. It's, I think you would join me in making it's a call to action, really, to say, come on, folks, this isn't going the way we want it to be, or any of us really think is right, and we got to do it. And if it may cost. If people get concerned about taxes and all of that, and I understand that. I mean, I don't want us to go broke, but at the same time, what's important? What's really important now? I mean, being able to buy, some fancy car versus, a kid's education. I mean, it's, we all have to make choices, and we all need to make smart choices. And I don't know that we're always doing that. And that's what we elect people to do, is to help us, lead us in some ways, making smart choices, educate us. I mean.
So it sounds like you're saying that we should help others.
Yes.
Right. What about someone learning to help themselves? Because we can overgive. And we're down to a minute.
Okay.
You want to come back and do part two?
Oh, sure. I'd love to. You made me feel very comfortable here, you and John and everyone else. I'd love to come back.
All right.
Sure.
We are going to have you back, Mr. Cicilline.
Okay.
Bud, this has been fantastic. As you know, I'm a licensed mental health counselor, and this conversation is just right up my alley. So fascinating.
Yeah. Oh, sure. Yeah, I'm a retired clinical psychologist, and I had a practice for a number of years, and there's a lot to be learned with respect to the interaction with each person. Everyone has a story and a life that is very important. So.
Thank you for joining us. I'm Darlene DeRezzo, host of State of the State. You can find us on YouTube, Vimeo, and also on Instagram @StateOfTheStateRI.